So good evening and welcome. Thank you all for being here for our faculty development session. I'm Diane Fairno in the GME office, in case I haven't met any of you. So it's my pleasure to introduce tonight's speaker, Dr. Eric Holmboe. We have been trying to get Dr. Holmboe here for many years. He is in high demand, so we are very thankful that we were able to get on his schedule this summer. He is currently with the GME. He is the Senior Vice President for Milestone Development and Evaluation. He did his, I'm going to go way back. Ready? All the way back to, right? Med school at Rochester, and then your internship with the Navy, and then your residency, chief residency, and ultimately a fellow, a clinical scholars fellow with Robert Wood Johnson, all at Yale, where he is also, continues to be adjunct faculty. So Dr. Holmboe joined the ABIM in 2004 in a largely research position. His interests are in clinical competence and evaluation. And then he took a position as their CMO from 2009 to 2014, which I think is when he began the bulk of his work in developing the internal medicine milestones, and for which he was either rewarded or punished, depending on how you look at it, with his current role with the GME. Dr. Holmboe has actually written the book on this topic, which is called The Practical Guide to the Evaluation of Clinical Competence. And I'm just going to quote briefly from that, and then I will let him expound. But he says that evaluation of medical trainees is hard but invaluable work. Evaluation of clinical competence is a core element of professionalism and underlies effective self-regulation. It's essential to fulfilling our professional obligation to assure the public that the graduates of medical training programs are competent to enter the next stage of education and/or practice. And so I think it is that has motivated us to invite you and all of you to be here this evening. So thank you very much.
Yep, thanks. So first, thanks for having me and also for coming out, on an evening. I know that you're all very busy, and I really appreciate the opportunity to interact with you. Believe it or not, the Milestones Project began in November of 2007. That was the very first meeting when the internal medicine community got together. So when I was invited by Tom Naska to join the GME and try to move this forward, I kind of saw it as an exciting opportunity, but perhaps also part of my penance for being there at the beginning, which is only fair. What I'm going to do is try to give you a little bit of background about what assessment looks like in the kind of next accreditation system era, and hopefully give you a preview into some early data and some helpful tips. The other thing I just want to emphasize, we really want to be helpful to you. There are a number of activities that now run through the Milestones Department. We honestly want to serve as a resource to help you. This is going to be very much an iterative process, and I'll show you through frameworks that we're using to think about our work. But the milestones very much fit within the CQI aspect of the next accreditation system, much like CLEAR. These are not high-stake things. The only high-stake things about the milestones is you have to report them. Other than that, it's really designed to help guide programs and making improvements and help residents and fellows progress throughout their training. And one of the things that we very much think about in terms of the milestones is really in the context of a system. And this is just kind of a simple definition from Edward Deming. He may have come up, particularly with all the work you're now doing in quality safety here with Rick Shannon. But one of the reasons I put this up here is that the milestones are just one part of a complex system. And they're interactional, interdependent on a lot of the other things that you do. And so when we think about the milestones, we recognize they're being embedded not only to an educational system, but also aligned and hopefully integrated with the clinical care system. And there's a lot of challenges in doing that. That's kind of new for us. I want to spend a little bit of time on this slide because for me it kind of really gets at some of the crux of why what you do is so incredibly important. So I sit on the right-hand side of that diagram. We're part of the professional self-regulatory system. And we're fortunate that in the States, we still have that privilege. That privilege, as you may know, in several other countries is eroded over time. The UK probably being the best example of that, with the creation of the General Medical Council, and the Royal Colleges actually have lost some clout as a result, mostly due to the perception that the educational system wasn't producing the kind of physicians the health system needed. And so I work in the accreditation side. There's certainly the certification and also credentialing entities, and there's a lot of overlap now between what we do. And we're kind of the public-facing arm of the self-regulatory system. But here's the bottom line. What happens inside that box is by far and away the most important thing. And I know right now that you're working to figure out what combination of assessments make the most sense within your discipline, that those serve as inputs in your clinical competency committee, where we know that when group process is done well from the literature, you can make better judgments and decisions, but that synthesis process is hard, and we're still figuring it out. And at the end of the day, you still have to make a judgment, right? Judgment is still a major part of the system. It's not a checklist or a checkbox. As I'll come back to, the milestones are not the totality of any discipline, and there's white space between the milestones within each discipline. And so judgment's still really, really important. And we need really, invested faculty to do that, because ultimately, you here at the program level decide if somebody graduates from your program. And that's really a critical entrustment that you make for the public, right? So if you graduate them, they will practice somewhere, but if they can't pass their boards, where they do poorly in residency, anybody want to guess on average where those people end up practicing and who they care for? They take care of the poor and underserved. That's where they end up. We know this. That was some of the research I was involved with previously. That just doesn't feel good. So what happens inside your institution is just essential. And ultimately, accreditation and certification is only as successful as you are. That's the bottom line, because you're going to make that decision. And one of the things we're beginning to work on is how do we create feedback loops. I'm going to give an example of one toward the end to really help both the local programs, but also how can we catalyze a national dialogue on where a discipline may need to do. And then also, how can this information be used to help residents to activate them? And one of the things that I think is very important is that residents have to become much more active agents, not only in their learning, but particularly in assessment, right? And one of the things to ask yourself, are your residents comfortable to come to you and say, hey, I'd like you to observe me today, or I'm not comfortable doing this, right? Because that developmental process is a very important part. And then how can you use the milestones data and other data to improve your program? This is from a recent article that I had the good fortune to write with Paul Batalden, who's very much a quality guru in the States, was actually there on the ground floor developing the competencies in the late 1990s. It's hard to believe that, believe it or not, the 6 general competencies were approved by the ACGME and the ABMS in February of 1999. So that's a long time ago. And I have to tell all of you as program directors that we've struggled to operationalize them. And one of the ways it was envisioned was to try to create language for the competencies that faculty and programs could get their head around, and that we could develop shared mental models. That is one of the drivers around the milestones, is begin to create a language that we can share across programs. It's messy, far from perfect, will need to change, but that was one of the primary drivers for starting the milestones. And you can see there's a number of other elements here that become key drivers as a result of these, quote, interventions. And the key driver again, something we use all the time in our quality improvement science. So milestones, exactly what are they? You already know that they're basically a point in development. I just want to point out that that is, in fact, a milestone and not a tombstone, okay? And really the goal here is to really help the resident or the fellow, the program, understand what the trajectory of development is for that individual. That's the goal here, really to get people to the highest aspect of competence we can. Not shooting for the floor. That's not the goal here, and sometimes that's confusion because of the terminology. This is just a typical milestone, and this is kind of the anatomy of a milestone. We kind of use milestones as shorthand for everything, but it's important to recognize that within the 6 general competencies, the disciplines have created what are called subcompetencies, right? And then the milestones are actually the narrative descriptors that have been created by each discipline to try to capture that trajectory over time. And you'll notice that most of them are described as levels, and they're not meant to tie to a particular PGY year. They're really meant to be agnostic to that. Obviously, we have constraints within our system, financing, service, all that stuff plays a role, but the milestones are deliberately designed not to say, this is where it should be a PGY1, PGY2, just levels, right? No, not really tied to year at all. The other concept that's gaining some traction and we're beginning to work with is the entrustable professional activity. How many people have heard of this concept? Some of you. Okay. This is something that was developed by Ola ten Cate and his colleague Fedashila in the Netherlands. They use this model in OBGYN training there and also in training physician's assistants and beginning to roll it out to other fields. But you can see this is the definition, and I think the most valuable part of this is the concept of entrustment or entrustable, right? Somebody who's demonstrated the necessary knowledge, skills, and attitudes or competencies to be trusted to do this without supervision, right? At that point, that's the decision you make. You let them go because you feel comfortable they no longer need some form of supervision, whether it be direct or indirect. And these are just kind of the criteria for an EPA. And a number of disciplines are now using the milestones and competencies to map onto EPAs to make sense of them so that when you produce somebody, you kind of have a sense of what it takes to do that particular activity. So I'm a general internist by training. One of the things that's really an important activity for general internists is to manage patients with multiple chronic diseases, right? That's what we often do. And I have a real interest in chronic disease management from my past life. Well, what does it take to do that well? Well, as you can imagine, all 6 competencies come into play. It's not just a single one. You got to have some knowledge around those chronic diseases. You have to have good patient care skills and doing diagnosis. But you also have to be able to work with interprofessional teams to manage chronic disease, right? And that's really critical. You got to have good system skills, right, to figure out how to use referrals and that network and what happens at discharge. That's a system problem, those handoffs. Also, how well am I doing? It's a practice-based learning, so I need to look at my quality data, and I need to know how the patients are experiencing their care. Therefore, I need patient experience surveys in some format. So you can see all of them come into play. And so when you kind of think about how we might use these, I like to think of them as a roadmap or a blueprint, right? They kind of help define the trajectory. We know that for residents, there'll be more than one path possible. And here's kind of the reality. All of your residents, by definition, will have a slightly different path, particularly if they're going through rotations, because everybody doesn't do everything at the same time. I may end up in the ICU in August as an intern, or I might be there in May. That's a different path. So how do we make sure those are pulled together from a developmental trajectory? And it avoids what I call the Yogi Bear phenomenon. If you don't know where you're going, any road will get you there. Or if you come to a fork in the road, take it. And this is from Bob Englander about how all this stuff maps when you think about the EPA and the competencies. So domain of competence is defined by Bob really as our 6 general competencies within medicine. There are lots of competency frameworks. They're being used throughout the world now. It's something that's really taken root in a number of health systems. And then the competencies we would call subcompetencies in the milestone language really describes in a little bit better detail what falls out each of those domains. And so this is how this fits together. And we're continuing to follow this. As you know, in the medical schools, they're looking at these kind of end of medical school EPAs in preparation for training, the kind of core EPAs. And so we're working closely with them to kind of figure out how this fits together. It's going to be a work in progress. And ultimately, this is what you hope will happen. You can figure out somebody's trajectory, and you hope that your curriculum and assessment are aligned and integrated. I'll come back to this concept a little bit later, because this is another really important concept. Does the curriculum provide the learning activities necessary to produce the kind of physician you want within your discipline? Or is there a misalignment there, right? So one question I would ask, I'm an internist, so if I'm going to spend 3 months in the ICU, but I'm going to be a general internist, right, managing chronic disease, what's the purpose of that ICU rotation? Why am I in there? Right? And map that, I think, is very important. There is a reason, but we often don't think about it. So how do we help our faculty get better at this? This is some work from John Norsini, kind of an expert in assessment. And what he points out is that most of our assessment methods, whether it be a patient survey, a multi-source feedback, an evaluation form, a mini clinical evaluation exercise, are largely based on some form of observation. And here's a really important concept. The form or the tool is not the measurement instrument. The faculty are. The person using the tool is the instrument. The tools are just a way to capture the information, and you want to make sure that you frame those tools in a way that helps them capture the information that's important, okay? Milestones can help, but they're not a substitution for helping your faculty. And even just having conversations around, so what do these mean? What does good development look like, right? Can be very helpful to faculty. This actually comes from science, that through conversation we can deepen our shared mental models by just simply doing that. It comes from something called conversation theory by Pascal Pangaro and others, that the mere act of talking about it will deepen understanding. And so it's important to think about how you can build that in over time. And there are models that are efficient to do that. We can spend more time when I finish talking about those. As I said, faculty and the encounters make the biggest difference. And a couple other really important concepts here. One is the form should comport with what's being assessed. This is where I think we're moving away from the generic evaluation forms because they're not terribly aligned with the purpose of that particular activity. That's a really important thing to take a look at. They don't need to be long. And it turns out from research that you can use whatever scale you want, so to speak. Doesn't tend to make a big difference on the ratings. It's really how people are prepared to use them. And another really important concept is something called construct alignment. This is work by Jim Crossley out of the UK, where if our forms are misaligned with the kind of developmental judgments we want to make, we're kind of in trouble. Good example is my field. Internal medicine for years used this 9-point scale where the anchors are unsatisfactory, satisfactory, and superior. So can you imagine taking those ratings into a clinical competency committee and asking, like, so where are they developmentally? Well, geez, all our interns are rated superiors, so I'm not really sure. That's an example of construct misalignment. And so we're probably going to have to rethink how we use these forms moving forward. And the milestones and EPAs can help in guiding what those forms should look like. But one caveat, and I strongly recommend you not to do, is to simply take the milestone document and turn the entire thing into an end of rotation evaluation form. That's not a great idea for lots of reasons. I'm happy to spend more time talking about that. But if nothing else, it's too much, quote, cognitive load for faculty. Another concept that's coming out in assessment is asking them to look for too much in a short period of time. So what's the reality of our assessment methods? Here's the bottom line. There's no holy grail of assessment. You're going to need some combination of tools to really help you. And as George Box, a statistician, said, all models are wrong, some are useful. What he meant was there's no single model that can provide everything you need. It's a combination of things. And so we often are looking for the holy grail of assessment forms, and we're continually disappointed. Because remember, the instrument is actually the faculty. And by the way, I have no relation to John Cleese, even though some people somehow think I look like him. Another important, I think, concept, and this is work that we've been doing around direct observation, is where do you anchor your observation and assessment? Traditionally, we've kind of looked at it from the lens of the dependent variable being the resident, and then we make all these adjustments, and what we tend to get is everybody rated highly. One of the things we would encourage you to think about, what if you grounded all your observations on whether or not the patient got safe, effective, patient-centered care in that encounter, and then worked back? So how much did the trainee contribute to the outcome of that particular visit or encounter, procedure, whatever it is within your field? I know we have a number of surgeons in the audience. And then what level of supervision makes sense moving forward so that your decision around supervision is deliberate instead of based on a time proxy. It's based on what the patient needs, but also it ties into what the trainee needs, right, based on where they are. And then certainly this all occurs in context. There may be a system issue. But if the system's dysfunctional that day, which I often experience in my internal medicine clinic, that's still useful feedback. What was it about the system that didn't work that impeded the patient getting what they needed that day? Something to think about. This is an article that Jen Kogan from Penn's first author on. And by the way, we've studied this with faculty. That paper is coming out soon. And faculty actually like this better in the study. And the reason was it feels less personal. If you ground it in what we all want, really high quality care for our patients, and then work back, the feedback was easier for them. So something to think about as you think about your own assessment here. So let's talk a little bit about system structure, because you're all kind of leaders within your program, and what does it take to kind of put this together? So this is kind of a straw man. Actually, something we wrote back in 2004. And these are kind of the components or structure. You certainly need some form of a data hub. I'm particularly fond of portfolios when they're done well. They need some structure because you have to put assessments into them. Obviously, program leaders are very important. But you'll see in this system, the trainee is an active agent in it, which, as we said earlier, is really important. And then having some sort of advising function or mentor function is also, I think, very important. Then we talk about the ComSig committee. So let's explore that in a little more detail. So when you think about it in structure, then we think about processes. And this is a very nice article from Kees van der Vleuten. This is what they do in Maastricht, and other programs around the world are increasingly adopting this as well, is that they make sure that the training activity is tied to the assessment activity. Because you've probably heard the adage, assessment drives learning. But learning should also drive what assessment's done. It should be a loop. And if your activities are not aligned with assessment, then it's hard to make good decisions on where they are developmentally and how to change your supervision. So again, I'll go back to my internal medicine example. If I'm learning to do chronic disease management, what are the training activities I need to do? Well, it'd be really good if I took care of patients who had chronic disease. That's best done in the ambulatory clinic. And who do I work with in the clinic? Do I work with an interprofessional team? Do I work with a case manager? How do I manage referrals? What's the system that's around me in that clinic as part of my training activities? Because we're also beginning to learn through other research that the quality of care you experience delivering during your training imprints. And that imprint tends to stay with you a long time. This is most notable in David Ash's recent work for OBGYN, that where you trained had a real impact on your performance as a practicing physician, and that imprinting appeared to last up to 15 to 20 years. In a recent study by Candace Chen looking at cost patterns, found the exact same thing in primary care. That what you experience, you tend to take with you, and it's stuck with you for a fairly long period of time. So I think that's really important as we think about the assessment and the training. What do they look like? How they integrate it? So for me, I would definitely need to get, again, an audit of my practice. I need those patient experience surveys. Those assessments should tie in to the training activities that I'm doing in that clinic. And then you can see from this diagram right here that, Case talks about having this intermediate evaluation before we make a final evaluation. And for us, we're using the Clinical ComSig Committee to do that. Right? You need to check in. They do this with their students at Maastricht. This is done at Dundee and other places around the world. But you need a way to synthesize. So the intermediate step is very important for us as the Clinical ComSig Committee. So let's talk a little bit then about group decision making. What do we know about it? So this is an actual report, as you can see, from a couple years ago in a program that was shared with me. This is the kind of grid that came out for this PGY2 resident. And I have to say I'm pretty impressed that they can actually take it out to the 100th decimal place on a 9-point scale. I'm not sure how helpful that is, but there it is. And so they have the average of the individual, and they have the average of the peers, and we kind of walk down there. So if you take a look at this, first you can see it's kind of the Lake Wobegon effect. And this person's probably doing better because they're a 0.5 percentage point higher on medical knowledge. So they must be better than the rest of their peers, right? And then we go down to practice-based learning and improvement. Well, that's actually really concerning because they actually got a 4 from one of the faculties. What does that mean? Gee, that's kind of concerning. They're below 7, right? The average is way above 7, so that's kind of concerning. And this is what I know Preston would be very concerned about. The professionalism rating is a 0.5 point lower, a little bit over 0.5. Maybe that's because they can't spell professionalism. That might be part of the problem. And so at the end of the day, this is kind of what it's been like for us, right? This old famous Sid Harris cartoon. You kind of get to a point like then a miracle occurs. And the reality is that's kind of true. We're very lucky in medicine. We work with really talented folks, and they do tend to figure things out, right? Just a show of hands. How many of you think you turned out poorly as a result of your residency? Yeah, exactly, right? I mean, we like to think we turned out okay, and I think there's some truth to that. There are parts of the system in the past that worked, pretty well. But I think we need to move past those kind of numbers. What kind of feedback would you even give to that resident? Listen, you got a 4 in practice-based learning improvement. Please work harder and do better at that. Great. That's really helpful. I have no idea, right, what the problem was. And so group decision-making can be helpful here. And these are some of the key issues that you need to think about. First, what is the environment which the committee works? What's the local culture here? Is it supportive of giving negative evaluations, right? How is the CUMSA committee even viewed by the rest of your faculty, the group within group culture phenomenon? Hierarchy, by the way, is a big issue for us in medicine. David Berg is an organizational psychologist at Yale I've had the good fortune to work with. And Dave has worked with all kinds of different types of organizations. He says the most hierarchical profession he's ever worked with is medicine. Oh, and by the way, David has spent decades working with the military, right? That's a profound statement from David. And one of the things he said is that one of the variables you can take a look at within your committee process is what extent are people willing to share both positive and negative things in that group process? Do they feel safe to do it? So that's what he looks for when he's studying groups. Anybody read the book by James Surowiecki? If you haven't, it's kind of a fun book. It's a layman's version around what good group process looks like. And when it's done well, the wisdom of the many is actually better than the wisdom of the few. And there's good evidence for that. These are some of the ways you can maximize good judgments, making sure you have a sufficient sample of inputs into that decision. That's why the assessments that flow into the CCC are so important. You want to make sure the people in that committee can have independence of thought. In other words, avoid the groupthink problem. And then you need diversity on the committees as well, to the extent you can. And we're part of the challenge there because of our rules around how much diversity you can have, and I fully understand that. These are a couple other key principles around group process. You want to make sure you come in without a predefined verdict. Right? You really want to review the evidence. It's fine to pre-digest the information, but you don't want to come up with a pre-digested decision. You want to make sure the group has a chance to reflect on it, look at the data even as you prepare it for them, because that helps you avoid something called confirmation bias, right? I don't know if you've ever had this happen to you when I used to chair the clinical competency committee at Yale. There'd be a group that comes in and they're just bound and determined. They've already made their decision. They're going to nail this resident, and our job was to rubber stamp it. And I said, well, maybe we ought to have a conversation about that first, right? Let's make sure that we've evaluated all the evidence we have. The second key principle is be careful not to overly emphasize consensus with regard to dissent. It turns out from the literature that minority opinions, even if they turn out to be wrong, are still helpful. They help the group revisit, recalibrate as necessary their decisions. So when handled well, they can actually be very helpful, even if it turns out they don't hold up. So be careful not to squash those. And also look for effects of hierarchy. One kind of general rule of thumb, start with the most junior person in the room. Right? That's one of the ways to minimize hierarchies, have them talk first. Because if you have a senior kind of physician with a lot of psychological size, and they say something the junior person doesn't agree with, they will tend not to speak up in general terms. So something to think about. Remember, this is not an inquisition, okay? Right? And interestingly, it turns out even the way that you arrange the room will affect the way decisions are made. Obviously, this is one I would not recommend. But how you even intersperse people makes a difference. So you might give some thought about what are we sitting around? Is it a square versus round table? Makes a difference. How we have people arranged. Do the senior people tend to clump in one end of the room and the more junior are kind of peripheral? That will affect decision making. So this is known as environmental competence around group process, and it's something that you want to basically take a look at and make sure that you're not creating a kind of physical environment that may actually squelch a conversation. There is data for medicine, not a lot, but there's been some nice work. Paul Hemmer found that many of the professional deficiencies were only discovered through group process, despite using a rubric called RHYME. Some of you may have heard of that. The other was Schwinn looking at a surgery program that found that about 1 in 5 deficiencies among their surgery house staff were only detected through conversation, again through group process, did not show up on the evaluation forms. And just something to keep in mind, it's really important, the conversations you have, whether they be a kind of a debrief at the end of a rotation, or in a clinical competency committee, are legitimate assessment information. Not everything has to be on a scale. If you capture those conversations and that narrative, they count. And by the way, they're defensible in court if you have to go that far. They hold up. So that's an important thing to hang on to. Not everything has to be turned into a number. The words matter. It can be just as useful, if not more. Again, this is Lou's study, matching people to a rubric using words tend to lead to better decisions. And then more recently, Glenn Regehr in Canada actually created a series of profiles very much like the milestones. In this case, there were 16 of them in internal medicine, then had the faculty match the resident to the profile using the words. And they found that that led to better discrimination, actually, than using scales. So I think this is, again, some early kind of signals. So then let me just, before I turn it back over and we have a conversation, let me share with you a little bit what we're learning. Because one of the things that's really important is to hear from you. And I want to encourage you to reach out. Had a wonderful conversation with Susan and Diane today. We want, like I said, be a resource to you. And by the way, there is a mailbox called milestones@acgme.org. You're welcome to send us feedback at any time. We continually monitor it, and we'll continually do thematic analysis. You're welcome to call me. But let me share with you a little bit what we've learned. So we know that this is a complex intervention, and we just, the reason this is important because it basically shapes how we think about evaluating the system. And this is a nice white paper from the Medical Research Council in the UK that basically talks about what defines a complex intervention. And you'll notice that a number of those things there, do they sound like your training program in the milestones? I'll bet they do. Right? A lot of the things around milestones really embrace the complexity issue. So one of the things that we've done over the past year is we've done what we call a listening tour. And that's why I'm very grateful that you're here tonight. So we go to institutions. We've been to about 30 over the last year. We've tried to capture as many themes about what's working and what's not as we think about the next revision of these. And also we've set up focus groups in a number of the society meetings. So I'll just share with you kind of some early common themes that have come out of those interactions. And at our last count, we've interacted with about 1,000 people over the last year through these activities. So these are kind of some of the early positive impacts we're seeing. One is that when done well, the quantity and quality of feedback to residents has been improved. And residents, and particularly in a number of programs, have noticed this. And that's encouraging. The CCC process among many programs has been felt to improve assessment. Again, lots of work to do. But we've also heard consistently that having a CCC has been helpful in dealing with residents in difficulty. Not only identifying them earlier, again, when it's done well, but also feeling that they have a way to remediate and having a better sense of what the problem is. Curriculum, we're certainly seeing some curricular changes as a result of the milestones work. Programs recognizing where they have holes or gaps, beginning to fill those. That's been really nice, and kind of think about what the curricular improvement should be. That's what we hope will happen. If you remember back on the key driver diagram, that's one of the hoped for outcomes of the milestones, is that it will also catalyze kind of a review of the curriculum to see what areas might need to change. For those who've been involved, the faculty feel like they have a better shared mental model of the competencies. This is particularly true among the faculty who serve on the Clinical Competency Committee. And then people like the kind of continuous quality improvement aspect of the system, right? Thinking of this more iteratively, not as kind of a checkbox, but kind of learning as we go. These are some of the challenges. I don't think they'll surprise you. Logistics and data entry has been challenging, right? It's definitely an additional time burden. We know that. And we're also working on trying to reduce the burden around data entry. So we hope to kind of launch more of that this fall. Assessment processes, lots of things have come up. Some of them are very milestone specific. So for example, in the internal medicine milestones, there's some, quote, negative language in the lower levels of the milestones, and some programs struggle with that. Other faculty are really struggling on how to adapt from the kind of previous evaluation system to the new system, particularly moving from a kind of normative system to a criterion-based system. That's very hard for us to do, just as humans in general. It's a lot easier to say, like, so Eric compared to Preston's, not quite as good. Preston's definitely an 8.989, so I guess I'll give Eric an 8.1, right? I mean, that's kind of how it's worked in the past. It's tough to kind of move to criterion, and we know that, and we're trying to help. I've already mentioned the construct misalignment challenge, language, and then also this issue of harmonizing things. This is kind of what I call the DIO's nightmare. Anybody want to guess how many different sets of milestones we have? Over 95, and they're growing. So we're adding the osteopathic and then some new subspecialties. One of the things we'll look to in version 2, can we potentially harmonize at least across the non-patient care medical knowledge ones? We'll see. But but I honestly don't think we need 95 different ways to evaluate professionalism. Preston, I don't know how you feel about that, but that's something we'll take a look at. And that's been challenging. So for your DAOs, that's really hard. And that was done, by the way, deliberately, because part of it was just trying to get buy-in. So the community built these things. These are your peers that built the milestones with input and support and the evidence that was available. And so there's a lot of latitude that was given to the disciplines. The downside is we have a lot of variability. Anybody want to guess which specialty is the winner with the most subcompetencies? They're actually in the room, I believe. Do you have any orthopods in the room? Yeah, congratulations, you have 41. Anybody know who has the fewest? That would be diagnostic radiology. They have 12. So somewhere in there, hopefully we can find a sweet spot as we move forward. Synthesizing multiple assessments into milestone judgments is hard. And I suspect you've had that same experience. And then last but definitely not least, time and resources. This is a direct quote from a program director: RVUs always win. And so that's a real challenge. My personal feeling, again, having been a program director and chair of a COMS committee in the past, is that we've really tried to do GME on the cheap in many respects, and I think we're paying for it now. And there's lots of pressures. We're very aware of that, and we're struggling about figuring out how to help with that. But we're certainly very cognizant of what it means for all of you. Let me just share with you a little bit of literature. This is now, by the way, available online. The emergency medicine community is actually pretty amazing. They've already published the first validity study using the national milestone data set from year one. I was kind of surprised because that first year tends to be messy. We expect that, not a problem. But as you can see, actually it held up remarkably well, even in year one for them. Part of the reason I think they were so successful is that they engaged a large segment of their community. Over 70% of the program directors touched the milestones prior to them going live. So they had built a shared mental model nationally, I think, earlier than most disciplines. And so I can see reliability was pretty good. The other thing was kind of neat, they did a factor analysis, and their certification process basically has three main components. And what was nice is that the milestones grouped and loaded onto those three main components, which was very reassuring. So there's something that's happening. And we saw a little bit more divergence in the last year as expected, because they're now moving into more elective work and they're beginning to pick paths. So this was all really reassuring and actually encouraging. We've got a lot of work to do. The other thing they found, and this is an article that's currently in a revise and resubmit mode, is that, as you would hope, the in-training exam scores correlated with the ratings on the medical knowledge. But what was also kind of encouraging is it didn't with the other subcompetencies. So in other words, there appear to be some ability now to discriminate among these different skill sets, and not everything loads on knowledge, which a lot of prior studies have shown. So we'll see. But some kind of encouraging early signals from the EM. And this is just how they distributed across the years. Interesting, not a perfect bell-shaped curve, but has that kind of shape to it. It shifts as you would expect across the years. The other nice thing about emergency medicine is that they actually follow the graduates out into practice during their first year and actually survey their employer. So we'll be able to see how this holds up and be able to do some correlation analysis, which we're now planning for, to see if these judgments hold up and how they do in practice. That would be very helpful, and that's kind of future work that we're planning for now. This is something else that to me has been really exciting. So this comes from neurologic surgery, and this has been kind of an unanticipated dividend. So it turns out in neurologic surgery, they have kind of 8 domains of kind of procedures that they have grouped in the patient care and medical knowledge. And one of the things that we were very worried about when we took a look at the data is like, okay, the ACGME says level 4 is what's the recommended target, but come on, you're the ACGME. You want everybody to be 4 regardless, right? So they just straight line it. So we were worried that everybody would be a 4 and the system would kind of collapse and would work from a quality improvement perspective. Good news is that didn't happen. In fact, it turns out that only 54% of graduate neurosurgery residents last year attained a level 4 in all of the 8 domains of procedures. Now, your first reaction might be horror. Actually, I think that's exciting news, and here's why. So it turns out that each resident kind of comes out as a slightly different package. Well, that's probably what you'd expect based on what the availability is of various groups of procedures, where they're training, and also what their interests are. And you'll notice here this is peripheral nerve surgery and movement and epilepsy surgery. They were the lowest as far as the number of residents who attained ready for unsupervised practice, if you will, level 4. And that wasn't a big surprise to them when they actually looked at it. By the way, these programs rarely get cited for volume on these procedures because the case logs only require 10 of these type of procedures. And we know that from a volume perspective, it doesn't necessarily correlate well with expertise. What's happened as a result of this data is that this community is now having an active national conversation about what this field ought to look like moving forward. Is this a curricular issue? Do people come out as unique packages, and as such, what are the implications for that? What do you tell the resident upon graduation about what their strengths are? If they're interested in doing stuff, how do they move past or move forward on that? And so what's wonderful is the RRC, the board, and the community, the Society for Neurologic Surgery, are having active conversations about how to use this information to improve the discipline and think about training moving forward. And they're also beginning to think about a national curriculum. They have said to us that they never would have had those conversations without this data, because they wouldn't have known. And because these are their judgments that they're making about their graduates. So to me, this is, just really wonderful that they're having a conversation, they're using this information to improve neurologic surgery training on a national scale. How cool is that, right? And as messy as it is, they're using this already, and so we're very excited about it. And we're trying to help them in any way they can, but this is part of the feedback loop we want to create for disciplines so they can use it to have those kind of conversations. That's what this is really ultimately about. And so that's just 2 examples. We have a number of studies going on. I'm happy to share more of those with you if you'd like. But we very much see this as a kind of an ongoing iterative process. And I love this study. This is from Holmboe, that actually looked at what it's like to actually have residents do a CQA project, particularly when they use PDSA cycles. And so they actually mapped out an actual experience with one of the projects, what the PDSA cycles actually look like. And you'll notice that it's not a nice straight line. There were certain cycles that had to be abandoned because things just didn't work, let it go. But ultimately, they kept moving up the incline, and that's the message. And I think this probably is what it feels like to you right now, be my suspicion. That it's not a nice straight line, that you probably feel like sometimes you're taking a step back. That's not uncommon, by the way, and we know that this is going to take some time. The other thing I just want you to know is that because these are complex interventions, another frame we're using for evaluation this is called the realist evaluation framework. There are a number of these that kind of deal with complexity. This comes from Paulson and Tilley. But the fundamental question here is what works for whom, in what circumstances, and why? This is where randomized controlled trials don't help you, because randomized controlled trials don't tell you anything about what happens inside the black box. We have to understand more what happens inside the black box. So some of our work is actually looking at the mechanisms of how milestones are operationalized, what's actually happening with competent committees so that we can develop best practice and get that out into the field to help people and develop better assessments and make connections for you. I shared some of those today with Diane and Susan about stuff that's happening so that we don't keep reinventing the wheel. That's part of our goal. And so this is part of the framing that we'll use for our work. So let me stop there and just open it up for questions, reflections. I would love to hear your thoughts. And thank you for coming out tonight and for having me. Yeah, please.
So, John Gage from Genesis. So thank you for that talk. And I just wanted to ask you about one of the things you talked about is how the group conversations can bring out deficiencies. And you certainly noticed that in our program. And it's been sort of problematic, I think, for a resident because they'll be getting these wonderful written evaluations. And they'll have 6 months of it. And then we have this conversation. And all of a sudden it's like, whoa. And when you sit down with them and give them this feedback, and they're sort of blindsided and quite. They then, I think rightfully so, don't trust the evaluation process. And most people sort of, and I think a lot of it's because faculty aren't willing to sort of put down on paper or directly discuss with the resident negative feedback and what you want to do.
Yeah, no, I've heard that, and that's actually been a problem even before, I think milestones. I think what's happened with milestones is we're probably surfacing more things now than we did before, which just exacerbates what you talk about. And it is kind of a major issue. So there's a couple things that you might consider. One is are the ways to help faculty with better feedback skills. And I think there's some better models that are coming out. One that's about to be published by Joan Sargent is called the R2C2 model. Should be out in academic medicine soon. And I'm happy to send you a brochure about what it looks like. That might be helpful. And there's some wonderful phrases faculty can use in that. I think the second thing that I've heard from other programs that I hadn't really thought about, but programs are actually using the faculty on the CCC to provide feedback to their peers about if you don't put stuff down, it makes it very hard for us to do a job. And remember, we're really trying to make sure everybody's successful. That's the goal. I mean, I got to believe that you didn't match people going like, well, 3 of them aren't going to make it, but that's okay, we'll just match them, right? I mean, how many people do that? That's like your worst nightmare. So you might think about how could you catalyze a conversation with those on the CCC with their faculty peers about how important it is to give you good information to make a good decision. Because ultimately, it's really to help the resident, right? And some places have real success with that. In fact, the program directors said what's nice about that is I don't have to be the baddie, right? It's now more of a peer communal process. So that might be something worth trying. The third thing is to make sure that the residents are kind of activated. So introduce quickly and early to the framework and empower them to seek out and ask for feedback and not to be afraid to push, like, listen, and say, like, what does he think I can do better? And so that activation part can be very important. And one of the things we talk about in the article is this concept of co-creation and co-production with residents, where they get greater kind of accountability and ownership for their learning, which they're going to need in practice, right? It's not like, this is going to be a foreign skill. So those are some things that you might think about how you might leverage that here. I don't know if that was helpful, but those are some thoughts. Great. Yeah, please, and then I'll go in the back. Yeah, go ahead.
Yeah, thanks. I gave up terminology. It's almost a
Congratulations.
I always suspected that this one was laborious, and then right.
Well, more laborious for you, that's for sure.
One of the things that you mentioned was to not use some of the milestones as part of to sort of separate that from the feedback, but yet I think your point, and I'm a good one about you're giving this feedback intermittently during the course of several months or rotation, and then you meet and you look at the milestones and you say, well, how are they doing the milestone? And so when those two sometimes don't line up, so I think how do we sort of make it so our feedback is maybe not the same as the milestones? In other words, well, you did a 3 on this procedure today, and then once you gave a 4, or you did a 2, but yet in a way that sort of matches up so that when we do come to that point, we can use it. Because one of the problems we have when we meet as a clinical competency committee is trying to determine, well, is such and such actually at level 2 on this particular procedure, which and a lot of our milestones are based on procedures or
Right.
specific knowledge.
Yeah, I mean, over half of yours are actually a combination of patient care, medical knowledge. Yeah.
So I mean, and it can be challenging because my specialty is trauma, so I do a lot of work with fractures.
Okay.
So does so-and-so know how to fix the tibia fracture? Well, I've seen them do 1, and they were okay at it. So
Right.
we'll go to the level 2. But next time it could be level 4 or it could be level 1.
Right.
So that's a struggle for us sometimes, and trying to. So I guess a bit of a rambling question. How do we get that intermittent feedback to better align with what we eventually want to do, which is to give them milestones, even if we're not using the exact same criteria?
Yeah, so there's a couple things that you might think about doing there. First, let me just clarify. When I say don't use the milestones, I don't want you to use the entire set. It's kind of a rotational evaluation. So it's kind of like asking your faculty to fill out, 30 sub-competency evaluations when they're only with them for 3 to 4 weeks just doesn't work. Having said that, if they're on a specific rotation, using the milestones as kind of an item bank and pulling out just some of the sub-competencies that make sense that you're going to basically expose is perfectly fine. In fact, may be helpful. Obviously, there's a lot more that underlies the language in the milestones that your expertise is needed. So what does a level 4 actually look like in the context of kind of fixing a tibial fracture in trauma? And so you want to be clear on that. So I think pulling out can be very helpful and kind of having them align or using that. For example, University of Washington does that in their internal medicine program. They use the internal medicine milestones as an item bank, and they pull out a subset that makes sense for that rotation. And they have the faculty really focus on just those things that really matter. You could do the same thing in trauma, decide how does that fit within the larger whole. So when you're feeding into the CCC, what is it you can tell the CCC and the resident is going to be most helpful? in the context of the rotation. The second thing, I think we're on the cusp of having some better assessment technology. So I'll give an example I shared today. There's several tools now where faculty can literally dictate in just their observation. So you could give your observation of what you experienced, and then there's a way to tag the text, which is converted from verbal into natural language processing in text. You can tag it to milestones, and I think that's pretty cool. And so they have a tool that UNC's developed. We're working with these folks to figure out how we can help accelerate scale. A gentleman by the name of Jonathan Fryer at Northwestern has actually developed a way where you dictate in the feedback, you tag it to an entrustment scale, so you could actually choose what level you think they're at based on that procedure. And oh, by the way, it's also tied into the EPIC electronic medical record, and so the case log is done at the same time as you're doing the feedback and the rating. It's all tied into a package. It takes 5 minutes. So I think those things would be helpful. But I would call out those things from your milestones that you think make sense on your rotation, and then focus on those. And it's fine to basically do it either through levels, or even you could do it through what's called an entrustment scale, about what level of supervision you think is required based on this one observation. The trick is, how do you collate that? Like you said, you may only see them once, but somebody else may get them in a couple weeks and they've made progress. How do you recognize that? And there are some systems that are being developed, but there may be ways to at least get started locally and kind of build that out. I'd be happy to share some of those references with you. That'd be helpful. Yes, sir, in the back.
So in medicine here, we have about 100 residents. In our competency committee, what we do is we divide up the tasks, and we report on a handful of residents, and one person will summarize that resident's status. Is that a fairly typical approach when you have large numbers to go through? And obviously, we focus in on people who are having problems.
Yeah, I think it's a wonderful observation. There's no question that the larger programs, this has been a bit of more of a struggle than smaller programs. There are several strategies, and I think we're still learning. I think your strategy is fine. I think the trick is to make sure that the individuals who are doing well, or actually particularly well, also get good feedback, and to make sure that they benefit in some way from some form of synthetic group process. It doesn't necessarily have to be a lot of conversation at a meeting, but that's something that would be important. Another way that people have handled this is basically have subcommittees where they take groups of residents, review them, and then the large committee basically just deals with residents and difficulties. The rest are kind of handled as a consent agenda, using that metaphor. That seems to work well, too. I think we're going to pay a lot of attention to the larger program. In some internal medicine programs, as you know, are 170. And so they've kind of set up these satellite things, and then they have a structured process and kind of flow chart about what happens if somebody's really struggling, and that tends to go to the larger committee. Remember, the purpose of the group process is to really to make sure that you're reviewing how they're doing, develop an action plan for them so that they know what the next steps are for them. And for most people, they're going to be fine. So it's really a learning plan or action plan. And then there are other people that will need more time, and that's perfectly fine. We just don't want the folks that are doing well to be shortchanged, because everybody can get better at something. So I'd love to hear about what your experience is and track that with you, so that you can potentially give us some insights on how to manage and give suggestions to others. Yeah. Any other questions or thoughts? Yeah.
Has your organization, Mark Abel, I'm one of the orthopedists as well,
Uh-huh.
as such I'm very concrete in my thinking.
That's good.
I'm wondering if your organization has thought more deeply about procedural training and how ultimately you worry about trial and error kind of training. You talk about advancing a resident
Yep.
against the patient in trial and error, and yet we have a real shortage of simulation models and access to cadaveric specimens. And ultimately, I don't know how you can teach procedures without in a low-stress environment without going to that age. And I'm wondering if your organization even discussed that.
Oh, yeah, quite a bit. And so John Potts, who's a general surgeon, actually oversees the review committees, the procedural committees, surgery, orthopedics, et cetera. That's an active conversation, and particularly in the context of supervision and what are the implications moving forward. Because at some point, you're going to let them go, right? So you have to give them increasing amount of kind of independence, so to speak, to develop that. So the other person, just so you know, that we've hired who's our vice president for evaluation research, is Stan Hamstrup. So Stan is actually a surgical educator who's worked extensively on these sorts of issues with Richard Resnick in Canada. I was previously at Toronto and then Ottawa. He's also worked extensively in simulation. And so we're very excited to have Stan on board. And Stan's going to be tackling a lot of this as we think about our research on the procedural side, working with John and other members. No, we're still in the early stages because we're still kind of interfacing with the community. So, for example, we've had conversations with the American Board of Orthopedic Surgery, talked with Shep Hurwitz about work we might do. The chair of orthopedic surgery at Duke, Ben Allman, was actually the chair of orthopedics at Toronto when they launched that pilot program. And so Ben's very interested in figuring out some of these things moving forward. And there's no question that simulation plays an important role, but it's not widely available, so that's another concern. That's part of.
One of the things they've done in Canada is there's no limit how long it might take you to finish residency.
Yeah, well, no, they've really adapted their system. As you know, the Toronto program, there is no time limit per se. They finish early, great. If they don't, that's fine too. And that now is the model. They train all orthopedists at Toronto, but they've also got a lot of support from the province. So, in that kind of closed system, the Ministry of Health and Ontario, to their credit, said, okay, we can put some extra funds into this where simulation is a big part of the modular training, and the return on investment is a better orthopedist for 35 years. Yeah, that's a good deal. We'll take that. We have such fragmented systems that it's very hard for that reason. Anesthesia, by the way, and oncology in Canada have also moved to that model in kind of a pilot fashion as of this past a year ago. So we'll see how that goes. They're also beginning to think differently about training where they'll have their foundational training. They'll take their certification exam now halfway through, right? So it won't be an exit criterion. It'll be something as kind of a gating mechanism to make sure they're okay. And then the last years of training are now called transition to practice. And the goal is to have it more as a mentored practice so they can really deepen their skills in a mentored practice model instead of just kind of throwing them out there after this. We'll see. But that's now going into effect. It'll be more widespread starting in 2016 and spread to other disciplines between now and 2019. So stay tuned. Yeah. They're working on it. I think they're trying to figure out how that they can scale it now. Toronto was a pretty unique place. They had the Wilson Center. Richard was the chair of that. They did extensive research. OSATs, by the way, came out of the Wilson Center. So I think there's a lot of interest in seeing how to scale that. I think Canada's probably going to make the investment. The other advantage they have is that all GME training goes through the medical schools. There's only 17 of them in Canada, right? We have 9,628 accredited programs spread out over 700 sponsoring institutions and 4,500 clinical sites. So we have some real challenges to think about how do you spread that nationally. And so, yeah, it's very much an active conversation. And feel free to follow up with John as well, or even talk with Larry Marsh, who is the chair of the RCs at Iowa. This is a very active conversation for them about what the next steps are. The orthopedic data, by the way, looks very similar to the neurosurgery data. So we've just begun to have those conversations about what are the implications for training moving forward. But we're a little bit earlier stage than neurosurgery. Yeah, please.